All right, wrapping up NYSATA this year, the 2022 conference was Dana Barsalow, who is a senior occupational therapist and certified hand therapist with Thomas Nicolla Physical Therapy. And she was talking to athletic trainers in the room about ulnar collateral ligament injuries of the thumb, not just standard ulnar collateral injuries, but also the other stuff that we need to look for when we have those injuries presented to us. So thank you so much for taking some time, Dana. I want to really get into the key takeaways you had. You gave us some tips on differential diagnosis of the various ulnar collateral ligament injuries. You talked about Sterner's lesion, the Adductor Pollicis, the thumb dislocation, the Bennett fracture, Rolando fracture. Kind of walk us through those and how do we differentiate? What are we looking for when we're evaluating?
Okay, so obviously you're going to do a visual assessment and just look for swelling and where swelling is located. And as far as with the dislocation, it's pretty visible deformity. So the thumb is actually just, a slight bit shorter, and you can see that, and it's got less range of motion at the MP joint. This occurs often with the Bennett's fracture, the Rolando's fracture, and just the dislocation. That is more visible. They're not going to have as much motion at the MP joint. So when you look at it, you can see that the thumb's shorter, and it's like an angulation change at the thumb. So it's pretty easily differentiated between just the UCL sprain. So then when it comes, if you note no deformity of the thumb, then you want to continue an assessment for the ulnar collateral ligament. These differential diagnoses that we just spoke about are actually infrequent. So the sprain and the ligament tear of the ulnar collateral ligament is much more frequent. It's very frequent in sports injuries. Obviously, it's the most frequent of the thumb injury and one of the most common of the hand injuries of all sports. So after you do your visual assessment, then you want to look at the thumb and palpate. And you want to palpate for two different reasons. You want to just palpate to see if there's soreness along the ulnar border of the thumb. And then you also want to palpate to see if you feel any mass. You will feel actually a mass if there's a Stenner's lesion, and that is a disruption of the ligament. And what happens with that is it is connected to the bone, to the proximal phalanx, and as the deviation force ruptures the ligament, it comes out of, it displaces, and then as it comes back in, it actually goes over tissue. So it's not next to the bone. So if it's not next to the bone, it cannot heal correctly. So with that, you want to make sure that that doesn't occur. And if it does occur, you will feel a palpable mass, and always check with the other side and just see if there's a difference. And then if that's the case, then that does require surgical treatment, and that cannot be managed conservatively. So you want to refer right away probably to an orthopedic doctor. Often these are missed. If you go to the emergency room or urgent care, they're often missed just by inexperienced healthcare providers. Got it.
And then what would be the difference between a Bennett fracture and a Rolando fracture? You mentioned those as well in your presentation.
Yeah, well, it's basically a Bennett fracture will have two kind of fragments, and this is at the base of the thumb. That's a good point too, Stephen. The fractures occur at the base of the thumb, and so generally the athlete would also have pain at the CMC joint. Gotcha. Rather than at the MP. So the Bennett fracture is like kind of a two-part fracture, and it's a partial intra-articular fracture, where the Rolando's is a three-fragment fracture. It's worse, obviously, and a little more severe, and that usually takes place on the X-ray. It usually is like a T or a Y shape, and there's three fragments to that fracture.
Gotcha. And you also alluded to the importance of immediate evaluation whenever possible, just because of swelling is fast, guarding, and a number of other factors that could really make you miss one of these fractures, especially or not to get a good read on the severity of the UCL tear. So it is important that we as athletic trainers are evaluating that right away, because time is crucial, especially in situations where surgery is needed. And can we talk about the rehab guidelines? First, the traditional UCL surgery. What's typically the guidance that you use timeline-wise with that?
Okay, so with the conventional surgery, which is usually used, they usually use an anchor or screws. That just so the sooner you get to that, the better results, obviously. And so if you wait after 3 weeks for the surgical repair of that, then the ligament is a little more stressed and it could take more time for the healing. So the sooner you get to the assessment and the diagnosis, then actually the sooner the athlete is able to return to play. That's taken care of. So with that time frame, the athletes or the patient are often in a splint for 3 to 6 weeks. Sometimes the doctors will cut down, it's usually a long thumb spica splint for up to 6 weeks. Often they'll cut it down to a short splint within 4 weeks. I noticed that the doctors are getting it moving much quicker. So they'll cut the splint down, but still the MP is protected for at least 6 weeks until they can remove it and start light activities and exercises. They'll start the gentle active range of motion exercises, around 4 weeks with the MP motion. No stress to the ulnar collateral ligament. With the repair, they want to avoid stress to the ulnar collateral ligament for 16 weeks after the repair. So they'll continue to wear the short splint for protection and through practices and for return, to play. But the rehab really starts about 4 weeks for range of motion, and then return to play can be often 3 to 4 months is pretty typical for that.
And then how does this internal brace approach that some surgeons are using now, how does that change that timeline?
Oh, that decreases it in half, actually. And there's been a couple of studies that have shown that they're able to get the athlete back to play within like 4 weeks. So that is a suture material that is braided and it's very strong. It's 5 times stronger than the normal repair. And that's because they use that in addition to repairing it. So it's a traditional surgery that is taken place. The last step though, however, is so the internal brace is on top of the ligament basically. And so they attach that to its site. And that's like the basic repair. And then what they do is they drill a second anchor at the MP, and they right below the attachment of the ulnar collateral ligament that has not bulged, and they anchor that suture material. And so it just provides strength. It doesn't make the healing process go any faster, but you can certainly start the rehab, because the biological healing for the attachment of the ulnar collateral ligament is like 12 weeks for it to really attach. And so this just allows you to start the rehab process 2 to 3 days to a week after the surgery. So you start that, yes, because it just it provides strength and protection really to that ligament that was just repaired. So you can start the range of motion right with 2 to 3 days, a week at the most after surgery. So that decreases the whole muscle atrophy, the whole stiffness, because at time 0, it is 5 times stronger than just the conventional repair. So athletes are often back to the sport within 4 weeks, and they also return to the same level of play before the injury took place. So it's not actually the conventional, you're still at a weakened state.
That's great to know. So it's very important, just like with every other surgery, athletic trainers need to really get those specifics from the physician who performed the surgery of which of these, because it varies drastically, that timeline. Let's say someone chooses not to have surgery, or for whatever reason, surgery is not an option, or the physician decides, this is not a surgical case, it's not as severe. What's that return continuum look like? How are you guiding your return to activity with a non-surgical injury?
That is really, you have to listen to the pain level. And I'll tell this from experience that this is not a no pain, no gain situation, unfortunately, because it's a healing ligament, and it's, already stressed, and they need to be in a splint for up to probably 8 weeks, 12 weeks. It really, obviously the surgeon guides this, but you can't stress that ulnar collateral ligament. So the return to play is definitely, usually 4 months. And some athletes are able to return with a protective splint, and it depends on the sport, obviously, but that is a very different process, just because it's all about that ligament healing properly and not being stressed. So every time if you stress it, then you're going to start all over with the healing process again too. So, and that is a little different in as far as position of immobilization. It's a slight flexion of the MP joint, and it's more ulnar deviated. So it provides the best position for the healing to take place.
Mhm. Awesome. Well, thank you for these tips. It's definitely really helpful to know. And I know that's your specialty. You're really focusing on this care with your patients. So it's always great to hear from specialists when it comes to various cases with our athletes. And thank you so much for taking some time to be on the podcast and for being a part of NYSATA 2022.
Okay, well, thank you so
2022.
much. Yeah. Thank you so much
Yes.
for having me.
You're welcome. Have a great day.
You too. Bye-bye.
Bye-bye.